Hi, this is a voiceover lecture on of reassessment and reevaluation and the use of outcome measures. So from this lecture, I hope you can understand the purpose of reassessment and reevaluation and identify how each is different, understand the collaborative natures of reevaluation, increase awareness of skills needed for completing a reevaluation, and understand the use and importance of outcome measures. So if we look at the definition of reassessment, it is, and this is taken also from some of your OT practice frameworks and the OT process, but reassessment is that frequent and regular assessment through the course of intervention. This is where you are assessing how your intervention session goes. You're documenting any observations that you make during your intervention sessions, any changes in function noted by your client that you're observing or that they report, and maybe noting any assessment components, if you will, based on your session. So again, with reassessment, you're just assessing how the session went. You're assessing if you're increasing or making progress with your client from one session to the next. And it's more of it's less of a formal process. Now, your re-evaluation is a periodic use of a specific assessment tool to complete a comprehensive evaluation. This is typically done to track progress, update any goals, and or identify whether or not you can or should terminate services. So I really feel like your re-evaluation is done after a certain length of time, and you may be re-administering some of your more formal assessment tools and doing that comparison of where were they at on admission, where are they at now, are we making progress, do we still have work to do, um, are we going to shift our focus based on what those reevaluation results are and change any goals that we may have set forth? So again, I feel like reevaluation is a little bit more of a formal process, where your reassessment happens pretty much throughout anytime you're giving an intervention. So the complexity of re-evaluation, as I stated, your evaluation is usually done initially, which establishes that baseline of occupational performance. That's your initial evaluation. And so when you re-evaluate, right, you may be using some of the same tools to determine whether or not that progress is existing. When you re-evaluate, you are setting a new baseline, and it documents, if you're making progress, the impact that your intervention may be having. This allows you to determine whether or not your services are effective, right? Which may be kind of a self-reflection, if you will. Hey, my patient is making progress. They were initially this when I tested them with the P-body, and now they're this when I re-evaluate them with the P-body. So all of these intervention sessions that I've done looking at fine motor skills is actually improving their daily occupations with certain fine motor skills that are required for those occupations. So again, this helps you determine if that occupational performance has improved, maybe that's regressing, or maybe it's remaining unchanged. So this was taken from Lippincott, Williams, and Wilkins, a text regarding the OT process map. And so again, we evaluate, we look at the occupational profile with our OT evaluation, the analysis of occupational performance. Based on that evaluation, we come up with overall outcomes or your goals. Once we identify those goals or outcomes, then we work on individual sessions with our interventions, right? We come up with that intervention plan. What are our long-term goals, our short-term goals? We implement our interventions that address each one of those goals. After so much time has passed, then we re-evaluate. So we reanalyze their occupational performance. We review any of those outcomes that we may have assessed or looked at from our initial evaluation. And then we identify, where are we going to go? Are we going to continue OT services? Are we going to discontinue OT services? And of course, this is all revolving around the use of evidence, the use of theory, your overall experience, your overall client preferences too, based on which impacts their intervention, which impacts their chosen outcomes. So I like this picture of this reevaluation process, an OT process. So during our reevaluation, collaboration is very important between the therapist and the client. Okay, and so typically when we first do our initial evaluation, we don't have that relationship yet with our clients, right? We don't have that rapport built. But with reevaluation, we've been working with our client for a certain period of time. We can identify that progress that they've been making. We can share with them the progress that we see with them, and they also can return and say, I really like this aspect of your intervention. I really feel like this part of your intervention is helping. However, I feel like I could focus more on this. Or maybe this occupation isn't as important anymore, but maybe they've identified another occupation during this time period. And so getting their feedback and giving and taking, it's a real good collaboration and a collaborative process that should be occurring with the client at this time. As OTs, we know that the client is an expert in evaluating their changes for capacity. So are they improving? Is their performance improving? Are they able to participate more? That may ring a bell with some of the models of occupation that we've been covering. I'm thinking of MOHO, the model of human occupation, that performance capacity, their ability to perform. Are they actively participating and engaging? The therapist then is the expert in understanding the causal link between health and that client's context, right? That client's situation. Their inability to participate and live life to the fullest, and how is that contributing to the overall health and wellness? So when we reevaluate the client, we sometimes choose another assessment tool, or an assessment tool that we did during that initial evaluation. We would be administering that again, kind of like that pre-test, post-test, and comparing the results. So typically we would use the same assessment tool because that more clearly would delineate whether or not there is progress being made, right? However, we may have to choose another assessment tool or a new assessment tool if there's a change in developmental level. Okay, so I'm thinking of, you guys are now familiar with the Peabody developmental motor scales, right? And so a child would likely age out of using that normative data with the Peabody at the age of 6, right? They would be kind of tapping the end there of that assessment tool. And so maybe you would want to start using the other assessment tool, such as the BOT2, the Brunitz-Odzoretsky. Both assessments measure those motor skills, fine motor skills, visual perception, visual motor, those kinds of things, very, very similar. However, based on the child's development, right, you may have to change it up a little bit. And if that child ages out of the Peabody, maybe you'll want to use the BOT2. You may choose a new assessment tool if they're transitioning to a different service delivery or a different type of setting, right? So maybe they're transitioning out of outpatient therapy and doing more of school-based therapy. So because the purpose of school-based therapy is a little bit different, they may have a different type of an assessment tool that they would want to use. Sometimes a significant change occurs with the client. I'm thinking more of those rehab types of situations where maybe it wouldn't be appropriate for you to test manual muscle testing based on pain, based on surgical precautions, those sorts of things. And after a certain amount of time of just overall healing, there could be a change in that client condition, which then we would be able to perform that given assessment. Change in performance areas. So maybe a client changes in a particular area, right? Or we identify another occupation that is affected that has a different performance area that we didn't assess or that we didn't follow a formal assessment with. And so then perhaps as that new information arises at the time of our reevaluation, maybe we want to use a new assessment that further assesses a different performance area that client is complaining of. Also, when we're reevaluating, any assistive technology should be considered if we're using or if it's used by the client. Because again, with our assessment and our reevaluation, we're trying to evaluate their overall function, and if their assistive technology is being used to increase their function, we want to make sure we're taking that into consideration. In the outcome measure that we're going to study further, called section GG, that was taken from the FIM, the Functional Independence Measure, which some of you guys are reading about probably with some of your validity checks with your assigned assessment tools. And so a big difference is with section GG, if they're using any assistive technology, or that can be accounted for with section GG. In the FIM, when section GG was formerly known as the FIM, any assistive technology, they were rated at a lower level, or a higher level of assistance was needed. And so section GG has sort of removed that, so we can take into consideration that a client can be independent with assistive technology and be functional with that device or with those devices. So again, the purpose of reevaluation is just to collect data during that initial evaluation and intervention, and then in our reevaluation, we are either re-administering pieces of that evaluation to determine any changes that has occurred for that client. And so again, we're determining, should we continue on our intervention plan? Do we need to modify our intervention plan? Or has the patient made enough progress to where we can discontinue therapy and discontinue our interventions? So again, that reevaluation, we're really highlighting those objective data and identifying if services have been making a difference in our clients' lives. When we terminate OT services, or we discharge a client or discontinue services, there's usually no uniform criteria for the termination of services. Typically, we terminate services when the goals have been met. Maybe we've been working for a considerable amount of time with every intervention strategy we can think of. We're looking at best practices, we're looking at what's in the literature, and they're just not being effective. And so if our interventions and our strategies aren't being effective, that might be a time when we're terminating our services also. In my experience, that hasn't happened very often. There's been a couple instances where actually there's one instance when I can think of that this occurred with a child that I was seeing. And at that point, we recommended some psychological services be picked up, some counseling services, some mental health services, and so I felt like we weren't making progress because of some specific behaviors that we were seeing, and I wasn't able to move through those behaviors with positive reinforcement, with charts, with all of these strategies that I had, and so I discontinued services. and basically gave the family and said, you know, I think at this point, I really wish, or I hope that you guys can, or I recommend um, that, you know, the child gets some psychiatric help, some counseling, some psychological consultation to really work on some of the behaviors that I was seeing. They were quite aggressive behaviors. Um, and because of these behaviors, you know, our interventions aren't necessarily helping, but they're more hindering and causing him to have more outbursts. And so really explaining that to the parents and really having communication about that, I think was really helpful. Um, they they ultimately were a little reluctant, and I could see the disappointment in their eyes. And it wasn't something where I just said, hey, we're discharging today. It was something that we had been talking about for quite a while. It was something that we had talked about, or that the third party payer had come back and said, you know, within the last 6 months, we haven't seen a lot of clinically significant progress being made. And so, um, you know, we probably recommend, or we're not going to pay for therapy services to continue unless something changes. And so I was able to have that communication too with the family and say, this is what I'm thinking. This is what your insurance came back and suggested. And so it was a few months, right, of conversations with them to get them to warm up to the idea. And when they did, and they did take the child, they ended up taking the child to a psychiatrist, and they prescribed some medication that helped with some attention, that also helped lessen some of the aggressive behaviors that the child was having. And so once they got those medications on board, and those medications sort of they were in their routine and those sorts of things, then they came back to therapy. And it was a few months later they came back to therapy. I was able to reassess, reevaluate, if you will, with another assessment tool, and we were able then to pick up where we left off. And so I think that was a real positive thing that happened. A step down approach also prepares for discharge. And so with some of our kiddos that are making enough progress, and I'm thinking of kids, this could be for adults too, but yeah, there's been kids that I've worked with that have started meeting their goals, right, developmentally meeting their goals. And I was able to say, okay, we saw your child for 2 days a week. They're really meeting their goals. I think we're getting ready to discharge, but let's cut down to 1 time a week for a couple weeks. We'll monitor how things are going, and then we'll cut down to 1 time a month, and we'll do more of a consultation and see how that's going. And if things are going okay, then we'll discharge at that time. And so making sure that you're gradually stepping down those steps helps maybe shift some of the responsibility from the therapist to the parent, making sure that you're following through with the parent, and making sure that you're not just cutting them off cold turkey, but you're following up with them and continuing to follow up with them until they feel confident that they can continue on their own. Now, I like the outcome measurement. I like to throw in with this topic, because so many times during our initial evaluation, we may be choosing to do some kind of a formal assessment. And at the time of discharge, right, we can perform that assessment and compare pre-test to post-test, right? And really say, hey, this person's scores increased this much, which means that my services I delivered are effective. Okay, and so outcome measurement can be a term, if you will, of using that pre-test, post-test design with your clients. You will find, and when you search outcome measures, right? OT has specific things that we like to consider as overall outcomes, okay, like wellness, health, quality of life, all of those things. And so those can be very difficult to specifically measure. And so OT in the past 10 years or so, and even sooner than that, have really been saying we need in our profession to have proof. We need to have clinical proof that our services are effective. And so we're all called to use some kind of outcome measurement in our treatments, in our evaluation, in our re-evaluation at the time of discharge, to make sure that our services are um, effective, that clients are better because of these services, that we've made a difference in our clients' lives. So if we look at the OT practice framework, outcomes are vital to health. Okay, the World Health Organization considers outcomes dealing with health and participation. And what's unique to OT is our outcome is just meaningful engagement in occupation, right? And so that can mean many, many things in how we engage in occupation. And so, again, if we go back to the OT practice framework, an outcome might be increase in occupational performance in any area of occupation. Okay, this might be related to ADLs, IADLs, rest, sleep, education, work, play, leisure, or social participation. So if we can measure or do a measure on any area of occupational performance at the time of our evaluation, and then again at the end of our treatment, and say, hey, our interventions increased occupational performance with activities of daily living, okay, or IADLs, or rest, sleep, education, whatever you can think of. One of the outcome measures that I'm going to cover is the section GG. Used to be known as the FIM. It's been slightly modified since then, but that really looks at self-care. Okay, and so again, using section GG could really help, or really be used as an outcome for OT with occupational performance and self-care, or ADLs here. We can also use outcome measures to look at any performance skills. And so I'm thinking again of maybe we want to use the use of the Peabody, right? A performance skill of fine motor coordination, which is affecting a child's ability to complete activities of daily living. Okay, so we could use that Peabody, we could use the BOT2, any other measure, if you will, that measures a performance skill. And it's us as the OTs identifying in our initial evaluation that that performance skill is affecting occupational performance. Some assessment tools or some outcomes we could consider contribute to health and wellness. Okay, some contribute to quality of life. So there's a particular assessment tool one of your peers are going to be covering, the stroke-specific quality of life scale. Okay, that could be used as an outcome measure with the outcome of improving quality of life. Prevention, participation, or even role competence. And so those are some of the OT-specific outcomes. We could look for outcome measures and make sure that we're including those with our initial evaluation, perhaps during a re-evaluation, and again at the time of discharge, showing that we are making progress, showing that we are meeting and achieving, or helping our clients achieve these really important outcomes. So how do we measure outcomes? So first we have to identify our client needs, or even our population if we're working with a population. Then we need to find a particular measure or a particular test. Let me tell you, there are thousands of them out there. And so even if you just Google or PubMed and you look for outcome assessment in OT, you will come up with some hits. you can go to www.rehabmeasures.org and you will come up with some hits. NIH, the National Institute of Health Toolbox, and you will come up with a list of outcome measures. So a lot of the outcome measures you can use might even just be simple, real simple ones. I'm thinking of the disability of arm, shoulder, hand, the DASH, right? It's a simple survey that the patient fills out relating to how their upper extremity injury or pain, if you will, is affecting their quality of life. And so doing that before, right, doing that maybe somewhere in between at a re-evaluation time, and then at the time of discharge, right, we can really see and use that outcome measure if we're actually improving quality of life. So some real common outcome measures that you may conduct, again, it used to be called the functional independence measure. When you're looking up literature and research, you're going to see a number of tools being compared to the FIM. And so the FIM has been modified, has been updated, and is now called Section GG. And so again, we will be covering Section GG in detail, and not way much detail, but in enough detail so you can get a feel on how that's used. There's also a child version called the WeFIM. One of you guys, or some of you guys, are going to be talking about the Canadian Occupational Performance Measure. Again, that could be used as an outcome measure. The Pediatric Evaluation of Disability Inventory, that can be used as an outcome measure. And the School Function Assessment, the SFA, can also be used as an outcome measure. So again, as OTs, we're really being called to use outcome measures to prove and to justify the quality of our services, and that we stand above and we are as good as or as distinct in making a difference in our clients' lives. So why do we use outcome measures? Okay, so we use outcome measures, and I've kind of drilled this into you already, to monitor progress. Okay, we can use outcome measures also to make predictions for discharge too. So if we know why a client is rating themselves low in a certain aspect of quality of life, we can then choose interventions that specifically increase those particular areas. And if we know where to target our interventions, that's going to help us predict when we can discharge somebody. It also can help identify the need for continued services, right? So if our scores on that outcome measure, if we're re-evaluating a client, we re-administer the outcome measure to the client may further see that they need continued services. Or also predictions for discharge. It will also give the client a heads up that, hey, I'm scoring really good on this outcome measure. I think I probably could anticipate that I would be discharged soon. Providers, or for us, again, it's going to monitor how successful our interventions are. It's going to make sure that we're really focusing on quality of our interventions. So if our progress is low, right, then we know, and we can measure that with an outcome measure, we know that we need to be harder on our client. We know we need to push them more. We know we need to do something extra. And so by getting that data from that outcome measure, we can assure that we are providing quality interventions. By doing so, and by making sure that we're using what's in the evidence, right, and we're pushing our patient more, we're being cost effective. So we're not just, making sure that, or we're not just doing the bare minimum, but we're really looking at, okay, if we can provide, or if we can push our client a little bit further, a little bit more, right? And we can get them discharged a little bit sooner. That's really going to help the cost effectiveness of therapy services, really. Also, it's going to help us with program development. So if we can use an outcome measure, right, to monitor progress, to make sure that our intervention is successful, that gives us evidence for whatever program we created, right? So maybe some of you guys are going to look at program development for your deck or for your program development course. And so I challenge you all to identify an outcome measure that you would use to determine how well your program, or how you're going to measure whether or not your program is effective. Payers. So I think of Medicare, Medicaid, right? The Center for Medicare and Medicaid Services help to establish reimbursement guidelines. So they can look at, so somebody who's had a stroke, right, usually goes into a rehab hospital at this level of section GG, this score. Okay, with 2 weeks of time at an inpatient rehab facility, they should be at this level. Okay, and so certain programs can go back and they can look at that and they can identify that on average, and they can share that with the reimbursers, with the third-party payers, and say our rehab is so good that we on average get people who've experienced a stroke, we get them at home living independently or with minimal supervision after 2 weeks of inpatient stay. And so that really helps guide your third-party payers as well. It helps develop policies and standards for overall facilities, for reimbursement for third-party payers too. So again, outcome measures can be really, really good at justifying even the need for more therapy, or to say, hey, we don't need as much therapy. And payers like to know that they don't have to pay for more than they have to. And so that, again, can be a real positive influence on why outcome measures are helpful for clients, for us as providers, and for payers.